Good afternoon and welcome to today's webinar, Health Insurance Updates and Open Enrollment for 2020. We'll get started in just a moment. I'm going to make sure that everybody has time to join. So we'll be starting a little bit after noon. All right, again, good afternoon and welcome to today's webinar, Health Insurance Updates and Open Enrollment for 2020. The presentation is intended to give general information and is not intended as legal advice. There will be time for Q&A after the presentation. I also welcome questions during the presentation if they would be beneficial for the group. One last thing. I also want to say that I hope to be able to answer your questions. But there may be instances I might have to tell you I don't know it, either because it's not information I have offhand, or it might be too specific for today. However, I encourage you to fill out an intake with us so that way we can properly research the information. The CLRC stands for the Cancer Legal Resource Center. We are a program of the Disability Rights Legal Center. The CLRC provides information and resources to people affected by cancer, including patients, survivors, caregivers, and healthcare professionals. Our resources are free, regardless of income. People often ask, what does cancer have to do with the law? This is a list of some cancer-related legal issues. Cancer affects the patient, survivor, families, healthcare professionals, and impacts many different areas of the law. If someone has a legal question and is affected by cancer, whether or not the topic is listed here, they can contact the CLRC for more information. If you would like to view our resources on any number of topics related to cancer, please visit our website. Educational webinars like this one are recorded, so we can later put them on our YouTube channel for you to share with anyone who may want to learn more about a variety of subjects. If you have questions about today's presentation, please type them in the chat box. I will be leaving time at the end to answer some questions. That part of the presentation will not be recorded. However, if you have questions about your specific situation or someone you know has a question you want to ask about, please fill out our online intake form. And you can see it on the screen, the CLRC, it's www.clrcintake.org for free customized resources so we can research laws and resources for you. Everything is confidential. With the generous support of the American Cancer Society and Breakaway from Cancer, the CLRC has a revised version of the Patient Legal Handbook. This handbook provides an introduction to the most common legal issues that a patient diagnosed with cancer is likely to face. It is available to download for free online in English or Spanish by going to our website, www.theclrc.org. Providers can request printed copies shipped to their offices. This webinar will give an overview of insurance basics, current insurance options, consumer protections, and ways to maintain or change coverage, whether you are shopping on or off the health insurance marketplace. I want to quickly go through some of the insurance basics with you. That way, if you're looking to purchase new insurance, you are familiar with the terms you'll be seeing. I know some of this is going to be straightforward, and a lot of you are quite knowledgeable when it comes to your health insurance. However, I just want to make sure everyone is on the same page. The first thing to remember is that it is the patient's responsibility to understand their coverage and limitations. Simply saying, "I didn't know that wasn't covered," doesn't work as a way to get out of a medical bill. Even when we call our insurance company, there's a recording that says verification of benefits is not a guarantee of coverage, or something to that effect. We can't always rely on the physicians treating us to know what's covered by our insurance plans and what isn't, or to what extent. Even if your provider's office says they will call the insurance company to find out, or tells you something is covered, it's always a good idea to become familiar with your plan so you understand copays, deductibles, and networks. This helps prevent unforeseen costs. So, in part one, we're going to go over some of the basic information everyone should know and understand about insurance. Knowing your insurance company, for example, and knowing that it's Blue Shield is not enough. If you call a doctor's office to make an initial appointment, they'll ask whether it's private insurance. That's because Blue Shield is also a Medicare and Medicaid provider in some states. Not all doctors accept all insurance plans. Private insurance is one you buy as an individual or family or get through your employer. Medicaid is insurance for people who are low income and meet other requirements. If you receive supplemental security income, known as SSI, you should be eligible for Medicaid. Medicare is insurance for people who have been receiving Social Security Disability Income, or SSDI, for 2 years, or are 65 years of age or older. Private insurance, as well as Medicare Advantage or Medicaid plans, can all be managed care plans, such as HMOs, PPOs, and POS plans. HMO stands for Health Maintenance Organization. HMOs usually have limited choices for their members because members have to select doctors and hospitals from within a participating medical group. This is why they're typically less expensive than a PPO. There are 2 types of HMOs. The first is where physicians practice in their own offices and belong to medical groups. This is called an Independent Physician Association, or IPA. Examples of these are Blue Cross and Aetna. The second type is a standalone facility, an insurance company hospital that you visit for all of your needs. The most well-known of these is Kaiser. The other types of private insurance are PPO, stands for Preferred Provider Organization. Here in this example, the network of providers is less limited than HMOs, and physicians are reimbursed at higher rates for services provided. However, PPOs are usually more expensive than HMOs. POS stands for Point of Service. These plans combine aspects of HMOs and PPO plans where you have to get a primary care physician to make specialist referrals like an HMO. Users usually have some freedom of choice in providers and even those out of network, such as in PPO, but with greater out-of-pocket costs. EPO. This stands for Exclusive Provider Organization Plan. As a member of an EPO, you can use the doctors and hospitals within the EPO network, but cannot go outside the network for care. There are no out-of-network benefits. Here are some other basic terms to understand. Copay. This is the fixed amount you pay for a covered health care service. This is usually paid when you get the service. Most office visits or specialist visits have a fixed copay amount that you will either pay in office or be billed for later. It is usually a good idea to become familiar with your copays for different services. For example, your insurance policy might charge you $20 for office visits and $40 for specialists. For example, if the next term is deductible, that is the amount you have to pay each year before your health insurance plan begins to pay. For example, if your deductible is $1,000, your plan won't pay anything until you paid $1,000 for covered services. So your first visit or visits up to $1,000 may all be out of your pocket. Coinsurance. This is usually the amount people are often surprised about. Most insurance, even the best insurance, simply doesn't cover 100% of the cost of a visit. People will usually have a coinsurance, which is your share of the cost of a covered healthcare service. It is usually calculated as a percentage. If you paid your copay, but you are billed a random amount like $8.93 for physical therapy visit that cost $89.30, that's probably a 10% coinsurance. So once you meet your deductible, you might have coinsurance on top of your copay. Also, it's very important to know whether or not certain procedures or services require pre-authorization. You may have to get your doctor to submit a prior authorization to your insurance company in order for a service to be paid. Getting something pre-authorized doesn't always mean that it will be ultimately covered. But not getting pre-authorization when you need it can create administrative challenges. Usually, pre-authorization is required for expensive procedures like MRIs. It is also important to understand your limits. I'll use physical therapy as an example. Some plans limit you to 20 physical therapy visits per year, while other plans allow you an unlimited number of visits. But you have to see your doctor every month for a prescription, so understand your plan's rules about services you will need. Okay, we have to understand our coverage and read our policies. But where do we find this information? Your evidence of coverage or summary plan description can usually be found on your plan's website. If you have coverage through an employer, you can contact your Human Resources Department to get a copy of the contract if you don't have it. The terms of the policy is the first place to look in determining what is covered. There are many federal and state health insurance regulations regarding services that healthcare plans must provide that would supersede those provided for in an insurance contract. This means that there are protections that exist as your rights, whether laid out in the plan or not. An example is coverage of pre-existing conditions and annual screenings without needing to pay a copay or deductible. Often, all of this information is available online through your health insurance company's website. You can also call your insurance company to request a hard copy of your plan documents. If possible, it is best to access this information prior to a time when the patient is in need of urgent care, so that you at least know where and how to access it should an urgent medical question arise. Now, just like with your overall insurance plan, it's a really good idea to become familiar with your prescription drug benefits. Medications must first be approved by the Food and Drug Administration, or FDA. Until a drug is approved, it cannot legally be given to anyone except through an approved clinical trial or a manufacturer's compassionate use program approved by the FDA. Each plan has a formulary or list of approved medications. Formulary medications can usually be prescribed without pre-authorization. Drugs on a formulary are typically grouped into tiers. The tier that your medication is in determines your portion of the drug cost. A typical drug benefit includes 3 or 4 tiers. Here's an example. Tier 1 usually includes generic medications. Tier 2 usually includes preferred brand name medications. Tier 3 usually includes non-preferred brand name medications. Tier 4 usually includes specialty and biosimilar medications. 3-tier programs do not have a unique tier for specialty medications. Now, this is important. The insurance company, not your physician, decides what is on their formulary. If your provider prescribes a non-formulary medication, check to see if there is a formulary equivalent. If not, talk with your healthcare provider about requesting special formulary coverage from your insurance company. Some insurance companies require step therapy. This is the practice of beginning drug therapy for a medical condition with the most cost-effective and safest drug, and progressing to other more costly or risky therapy only if necessary. It is important to work with your doctor on appeals to discuss why the prescribed medication provides the patient with the best possible outcome. Compassionate use programs. They allow a manufacturer to give certain individuals a medication that is being tested in clinical trials before the FDA has made a decision about approving or not approving the drug. When the FDA approves a drug, it is approved for certain conditions or indications, as you can often see on the label. Regardless of what the label says, a physician can legally prescribe an FDA-approved drug for any reason. This is called prescribing the drug off-label. Note that your insurance company may not approve the coverage. Finally, if an insurance company is repeatedly issuing outrageous refusals to provide medication, some desperate patients have taken to social media, including Twitter and Facebook, and they've also enlisted their friends to publicly demand coverage, often with effective results. Patients can check with their insurance companies to see if the insurance companies offer a case manager. Case managers can be your go-to person for information about your plan, and often they will even go through appeals or advocate on your behalf to gain coverage or reduce costs. If your plan does not offer case managers or patient navigators, ask to speak with the same person each time you call a certain department, if possible, and then write down their last name or employee number and extension. It is helpful to keep one contact for each department and make friends with them, because some positive rapport can go a long way towards saving a lot of money if they spend time finding ways to reduce your costs. You can also avoid having to re-explain your entire story each time you call. Keeping track of your contact and who they are will assist with keeping accurate records, including careful notes of each phone call. Details such as date and time, names of contacts, information covered, authorization numbers, any written communications, copies of bills, explanation of benefits, check stubs, etc. You get the picture. These are all helpful for appeals. Maintaining an accurate journal or binder of notes will lend credibility to you if there is a discrepancy. While this is a lot of work, filing systems are helpful to assist with keeping track, and it may be helpful to use a notebook to contain information. Pre-authorization, otherwise known as prior authorization, is a decision by your health insurer that a healthcare service or prescription drug is medically necessary. Pre-authorization doesn't always mean it will be authorized. If you have to get a prior authorization, ask them to send you a written copy of the prior authorization. This should go without saying, but open all of your medical mail, even if it seems daunting. If you are opening your mail, you have taken the first step to understanding what you are up against. Sometimes there is no way to appeal decisions if you've waited too long. Thus, it is important to check for mistakes early. Review all bills. Mistakes happen. A simple phone call sometimes helps. Review each charge. We have a handout on our website with some helpful information about medical billing. You have to play an active role in your healthcare delivery, including the billing, payment, and payments. It is important not to be caught unaware of what your coverage is. If you read something that you don't understand, call customer service. Take notes. Beyond just knowing what kind of plan you have and how much your deductible is, you might need to know what percentage of certain services are covered and who is in your network, and whether they reimburse for out-of-network coverage. If you don't have the energy to do this, see if a friend or family member that you trust would be willing to do this for you. Now that you know what kind of insurance you have and some of the basics about insurance generally, and how to maximize that coverage, let's talk a little bit about some of the rules about coverage. as well as some of the options you have if you need to purchase new coverage. I want to clarify a few terms that refer to different types of health insurance. Group. That means purchased by an employer and offered to eligible employees of the company and their eligible dependents. The employer selects the plan or plans to offer to employees. The premium cost is normally split between the employer and employee, and there is a minimum percentage rate the employer must contribute. Individual. You must purchase, individual means you purchase individually for yourself and or your family on your own or through the insurance marketplace created by the Affordable Care Act. The Affordable Care Act is also known as Obamacare. These are often purchased with the guidance of an insurance agent to help navigate plan choices and premium costs. Insured is the more traditional way of providing employees with health coverage, where employers buy a health plan from a company and the employer either pays a portion or the whole premium. This is a fully insured plan. Self-insured means an employer just opts to pay the employee's medical bills directly. This is more common in larger companies, and often people don't know their plan is self-insured because an employer may use an insurance company like Blue Shield as a third-party administrator. Figuring out whether you have a self-insured plan is important when it comes to health insurance appeals. Grandfathered plans, that's in red on your screen, is created and purchased before the Affordable Care Act on March 23, 2010. They don't have to follow the new rules. Make sure to check the date of when your plan was created. Some self-insured plans don't have to follow the Affordable Care Act because they were created before the Affordable Care Act was implemented. Those are called grandfathered plans. Under the Affordable Care Act, which passed in March 2010 and was fully implemented in 2014, a lot of changes took place. One of the most important is insurance plans that count as minimum essential coverage can no longer discriminate against anyone with a pre-existing condition or genetic predisposition, like including cancer. The pre-existing condition rule is true for health insurance, but not to life insurance, disability insurance, or long-term care insurance. Some states offer protections for people with pre-existing conditions who want to obtain those types of insurance, but this topic is out of our scope for this presentation. Now, for health insurance, you could not be discriminated against because of a pre-existing condition. So, for anyone with a cancer or a positive genetic test for a predisposition to cancer, you can still buy COBRA, marketplace insurance, and get Medicaid regardless of your health history. Your age and where you live are the only personal characteristics that can be used to set rates. This change is significant because before 2014, gender was a determining factor in establishing premium rates, and women were being typically charged a higher rate than men. Now, gender cannot be a determining factor in setting premium rates. Rating area is an area used for determining premium rates, usually by zip code. The premium is based on the average healthcare costs and physician or hospital discounts in that area. So, costs may be higher if you live in a metropolitan city versus a small town. In late December 2017, Congress successfully passed the Tax Cuts and Jobs Act, repealing the penalty for the individual mandate. The repeal of the penalty went into effect this year, 2019. You will still be required or mandated to have insurance because the mandate itself was not repealed. However, you will not have to pay a fee if you do not comply. Additionally, you must still report that you had creditable, in other words, minimum essential coverage to the Internal Revenue Service or IRS or request an exemption. You were still responsible for having insurance for the 2018 tax filing season or risk a penalty of either $695 for an adult or 2.5% of the household income, whichever is higher. In more recent ACA news, some folks may have heard of the December 2018 case from a district court in Texas. It ruled that the individual mandate, which is the ACA's minimum essential coverage provision, was unconstitutional and invalidated the remaining provisions of the ACA as inseverable, and the current administration's decision not to defend the entire ACA. The individual mandate is that most people must maintain a minimum level of health insurance coverage, and those who do not must pay a financial penalty. So, where are we now with this? Appeals of the federal trial court's decision are with the U.S. Court of Appeals of the Fifth Circuit. This covers Texas. Oral argument took place in July 2019, and no court decision has been made. The CLRC is paying close attention to what's happening, so feel free to check with us if you have questions about any future changes to the law and how they may impact you. But as a reminder, the ACA consumer protections still exist. Preventive services still have to be covered by insurance plans. Young adults stay on their plan through age 26. Health insurance plans cannot impose lifetime limits and cannot discriminate against people with pre-existing conditions. If you're looking to purchase insurance through your state's marketplace or healthcare.gov, we are getting to a critically important time of year. It is important to keep in mind that you can only purchase or change plans during open enrollment or if you are eligible for a special enrollment period. For healthcare.gov, open enrollment is from November 1st to December 15th. Now, some states have their own private online marketplace, while others use healthcare.gov. When you enter your information on healthcare.gov, if your state has its own marketplace, you'll be directed to that marketplace website. Something that's important to highlight is that open enrollment time is limited to 6 weeks. And unfortunately, this can reduce enrollment. States that run their own health insurance marketplaces can and do have the option to extend this period. Another thing to keep in mind is that regardless of when your state's open enrollment period ends, if you want coverage for January 1st, you generally have to apply by December 15th. It's a good idea to check with your state's marketplace as soon as possible to confirm your state's deadline for applying for coverage. Plans in the health insurance marketplace are organized by metal categories: bronze, silver, gold, and platinum, as you can see on your screen. These categories are based on how you and your plan split the costs of your health care. The quality of care is the same. For bronze plans, the insurance company pays 60% of costs and you pay 40%. For platinum plans, the insurance company pays 90% of costs. You pay 10%. It may be tempting to buy the cheapest plan, the one with the lowest monthly cost, but some of those plans with lower premiums may end up costing you more in the long run. That's if they have higher deductibles or higher out-of-pocket costs. When you enter in your income on the website, you'll learn whether there are tax credits to help you lower the cost of your insurance premiums each month. If you are below 400% of the federal poverty level, you may qualify for tax credits to lower the cost. However, there are many gaps that exist for making plans actually affordable for people, whether they receive tax credits or not. In addition to price, when you're shopping for plans, compare all the different insurance company plans. Depending where you live, there may be many options or only a few in each category. If you like your doctors and providers, first check with those providers to see which marketplace plans they accept. You may want to choose your health plan based on doctors in the network. An example is when our office had HealthNet, we had a slightly different network of doctors than we now do after we changed plans and moved to Blue Shield. Tax credits are now available for people under age 65 who purchase coverage on their own in a health insurance exchange and are not covered through their employer, Medicare, or Medicaid. Premium tax credits will be available to help people pay for health insurance that will cap premiums on a sliding scale from 2% to 10% of income. Tax credits are used when you enroll and are paid directly to the cost of your health plan to try to keep your costs down. You do not need to wait until you file a tax return at the end of the year. Tax credits are only available through the exchanges. You must enroll in a health plan through your state's healthcare exchange or healthcare.gov if you want to use your tax credits. At the end of the year, the tax credits may be adjusted if your actual income is different than you anticipated. This means that you will want to notify your state's healthcare exchange or healthcare.gov if your income changes. It's always a good idea to look at your options off the exchange if you aren't eligible for financial assistance. For example, if you are on Medicare or if you earn more than 400% of the federal poverty line, some plans might be less expensive. You can always go directly to the health insurer's website or call a broker. The same plans might be available off the exchange and may even be less expensive. If you're curious what the process looks like to shop for an insurance policy, let's use Covered California as an example. These are questions they ask to determine your rates. The most challenging part of this can be entering your household income because you're supposed to anticipate what your income will be next year. That can be tough if you're contemplating leaving your job or if you are in and out of the workforce. There are also ways to search for doctors and facilities. However, although these systems have improved since year one, I strongly encourage you to call your doctor or hospital directly to confirm whether they accept marketplace insurance plans. Many facilities have decided not to accept marketplace plans due to the lower reimbursement rates. So don't just assume that because your doctor accepts an employer-sponsored Blue Shield or Kaiser plan, that they will also accept Blue Shield through Covered California. Make sure you ask. This is especially true if you have surgeries or other follow-up appointments scheduled. The most important thing for you may be to stay with a specific doctor. In that case, I would ask the doctor or facility first which plans they accept. Then use that information to search for those plans either on or off the marketplace. Here are a few examples of some plans that were available in the Los Angeles area. I know it's very small, but you can compare the prices of these bronze plans. There are generally more HMOs and EPOs on the marketplaces this year. For anyone with a complex chronic health condition, a PPO is probably going to provide more flexibility and will likely have a broader network of doctors, even if the premiums are higher. Here is an example of a Silver Blue Shield plan that was available in the Los Angeles area. You'll initially see the monthly premium, deductible, primary care visits, etc. If you're on the actual web page, you can click on Compare or Summary of Benefits and Coverage. That way, you'll get to see a lot more information about the plan. You may be particularly interested to learn about the prescription drug benefits. Thus, it's important to check the formulary of the plans you're looking at if there are specific prescriptions you need. I want to flag that if you are eligible for Medicare or Medicaid, you will not be eligible to purchase insurance through the insurance marketplace. Now, just to clarify some vocabulary, Medicare is for those 65 years of age or older, and Enrollment begins within 3 months of your 65th birthday, or those under 65 but who have been receiving SSDI for 24 months, or people that have end-stage renal disease. You still become eligible for Medicare at age 65, even if you have to wait until 66 or 67 to collect your Social Security retirement benefits. You do have to have worked long enough or have enough work credits to be eligible for free Part A Medicare. However, Medicare eligibility is not specifically tied to whether or not you were currently receiving retirement benefits. Traditional Medicaid is generally for those who meet categorical requirements, are aged, blind, or disabled, according to Social Security, and have limited resources, taking into account the things you own, cash on hand, but excluding the home you live in and the car you use. If your income is less than Medicaid limits for your family size, you will receive Medicaid at no cost. Since today is October 18th, Medicare's open enrollment period has already begun. You can now go to Medicare.gov to make changes to various aspects of your coverage. You can switch between original Medicare and Medicare Advantage, depending on what works best for you. Even if you're satisfied with your plan, it's a good idea to look at what options are out there. Also, plans change from year to year, and so can your healthcare needs. Medicare enrollment periods. Initial, from 3 months before your 65th birthday until 3 months afterwards. Open, once a year, currently between October 15th and December 7th. Special enrollment. If you have healthcare coverage through you or your spouse's job after turning 65 in a company with more than 20 employees, one is eligible for enrollment until a specified period after coverage ends. Medicare Parts A, B, 8 months following the month the employer or union group healthcare plan coverage ends, or when the employment ends, whichever is first. Medicare Parts C or D, during the 63 days after the employer or union group health plan coverage ends, or when the employment ends, whichever is first. These are 2019 numbers. Your tax returns are used to calculate Medicare costs. It is based on your modified adjusted gross income, or MAGI. Part A is free for many people. In other words, they have no premium. A person would only have to purchase Part A coverage if they are over 65 but have never paid into Social Security. This generally only applies to people who have no Social Security work history or insufficient work history, such as a stay-at-home parent. For people who pay a Part A premium, the 2019 Part A monthly premium is $437 a month if you paid Medicare taxes for less than 30 quarters, or $240 if you paid Medicare taxes for 30 to 39 quarters. The Part A Medicare inpatient deductible is $1,000 $364 in 2019. The average 2019 Part B premium is $135.50 per month or higher depending on income. There's also an annual deductible of $185 per year in 2019, which may apply to certain services. People with high incomes, $85,000 individually, and $170,000 for married couples, have a higher Part B premium, while people with limited incomes may be eligible for a Medicare savings program for help with paying their Part B premium. In a Part C plan, you must generally pay the Medicare Part B premium. Some Medicare Advantage plans may also charge you an additional premium. On average, Medicare Advantage premiums will decline while plan choices and new benefits increase. On average, Medicare Advantage premiums in 2019 are $28. Costs vary by plan, but the average monthly premium for Medicare Part D is $32.50 in 2019. People with high incomes have a higher Part D premium. The deductible varies by plan as well. For Part D, Medicare offers different levels of low-income subsidies called extra help, which can be applied for by submitting an application to Social Security. These pay the cost of prescription drugs above and beyond a standard Part D prescription drug plan. To qualify, you need to receive Medicare and have low income and assets. To qualify in 2018 for extra help, a single person had to have $12,140 or less of annual income. Here are some resources. We highly recommend the Medicare Rights Center and your state health insurance assistance program. For additional Medicare resources, you can contact our office through our online intake as well. Also, check the requirements and eligibility if your state has a health insurance premium payment program. While our healthcare system was greatly reformed through the ACA, that was a great start, but we still have a long way to go. There are still many people who fall through the cracks and cannot afford coverage. Many people with an undocumented immigration status or those who live in states that haven't expanded Medicaid need to find other ways to get medical treatment. If you can't get health care during any of the ways we've talked about, here are some options. Hill-Burton is a congressional law which gave hospitals and other health facilities money for construction and modernization. In return, the facilities that received these funds agreed to provide a reasonable volume of service to persons unable to pay. While the program stopped providing funds in the late 1990s, certain healthcare facilities are still obligated to provide free or reduced cost care. You can call the national hotline to get a list of obligated facilities. There's a separate contact number for Maryland residents. Charity care. Many hospitals have free or low-cost care available to low-income patients. Speak with a social worker or the patient services department at your local hospital to determine which options may be available. Hospitals cannot charge uninsured individuals who qualify for financial assistance more than what they charge insured patients. The limitation on gross charges applies to all hospital care, not just emergency care. Private health insurance. Although this can be an expensive option, anyone can purchase private health insurance coverage as long as they do so directly from an insurance company or through an insurance broker. Sometimes a phone call can result in a lot of savings, and other times a formal appeal needs to be made, but it starts with knowing your plan. Now that you know what kind of insurance you have and some of the basics about insurance generally and how to maximize that coverage, I want to talk a little bit more about the rules about coverage and options you have if you need to purchase new coverage. And here are some ways to maintain or change coverage. Here we have COBRA. If you are employed or recently employed, COBRA, which is the Consolidated Omnibus Reconciliation Act, allows you to continue on your employer insurance for a period of time even when you're no longer an employee. COBRA is a federal law that provides for continuation of coverage. Under COBRA, a former employee keeps the same insurance if they lose their job or drop below the number of hours required to get insurance through their job, or if they lose coverage if their spouse was providing by divorce, legal separation, or death, or they become entitled to Medicare. It's expensive, but it may be the best option for people currently undergoing treatment. A patient can continue the same insurance coverage from their employer without having to switch doctors. So if someone feels strongly that they need to see their specific doctor for as long as possible, even if the cost is higher, this could be a good option. One downside is the purchaser will pay the full premium, the portion they were paying as an employee, plus the portion their employer was paying, and an administrative fee totaling 102% of the monthly premium costs. Most people know about COBRA, but many people don't know that some states have laws similar to COBRA that apply to employers with fewer than 20 employees, or that extend the time period that a person may be eligible for continued coverage. For instance, in California, CalCOBRA applies to employers with 2 to 19 employees and lasts up to 18 months. Or for those working for an employer of 20 or more employees, this law may extend regular COBRA coverage another 18 months, equaling up to 36 months of coverage. Now moving on to Medicare, age gap and disability. If you're under 65, you may notice there are certain gaps in the insurance system. The first is that the person is only eligible for Medicare if they're under 65 and have been receiving SSDI for 2 years. Therefore, a person under 65 who becomes disabled has a minimum period of 2 years before they can access Medicare. After receiving SSDI, a person who was previously eligible for Medicaid due to low income may lose it due to the income they are receiving from SSDI. This creates a problem of figuring out how to get insurance while you wait for Medicare to kick in. Options include COBRA or purchasing insurance through the health insurance exchange. Some states provide assistance to making COBRA payments through programs such as the Health Insurance Premium Payment Programs, known as HIP. In addition to these gaps while waiting Medicare to kick in, plans that might be required through insurance companies to supplement Medicare, such as Medigap plans or Medicare Advantage plans, are currently allowed to hike up prices to people who are under 65 because they believe that the cost for a person who's disabled may exceed the cost for an average person reaching age 65. We also have some helpful resources on our website, and I'll pause for a moment in case you'd like to jot any of this information immediately down, including a step-by-step guide to insurance appeals and a handout with information about accessing prescription drugs. Here are some other related areas for accessing insurance-related resources. We have now reached the end of the presentation on health insurance options. Thank you so much for your attention. If you have general questions about today's presentation or need some clarification, I'll take time for questions. I won't log off just yet, but I'll end the recording now to answer questions if there are any.